Greetings to all the PhysioTV viewers. So, last week we kind of heard the part 1 of Anatomy Integrated Biomechanics, talked by Dr. Dharmang Vyas, and today we are going to hear the part 2. So, I welcome again Dr. Dharmang Vyas, who is teaching at the Parul Institute of Physiotherapy at Parul University, Vadodara. And sir is going to take the part 2 of his talk, which is going to be on the anatomy integrated biomechanics of the shoulder girdle. Over to you, sir.
Okay. Hello, friends. So here we meet again today. Welcome to the second part of anatomy integrated biomechanics. And previously we talked about the structures around the glenohumeral joint, how do they function, coordination, the muscles that create motions around the scapulothoracic joint, and how important it is to have normal motions at the scapulothoracic joint, sternoclavicular, and the acromioclavicular joint to have a full range of motions at the shoulder girdle. And how do the muscles around the shoulder girdle work in coordination to create motions. So what is the ratio of movements at the shoulder girdle? 60% of motions come with the glenohumeral joint, and rest 40% of motions comes with the scapulothoracic joint. And this is what we call as the scapulohumeral rhythm, which is normally called as 2:1 ratio. 2 indicates humeral motions and 1 indicates scapular motions. So it is very important for us to have a normal scapulohumeral rhythm in order to have a complete range of motion at the shoulder joint. And that is why it is very important for us as physical therapists to integrate this scapulothoracic motions or to restore normal scapulothoracic motions to have full range of motion at the glenohumeral joint. Next, coming to a very important component, this is where we have the rotator cuff group of muscles. So representation of the influences of rotator cuff muscles on the shoulder girdle. How do the shoulder girdle works as the stabilizers? How does the rotator cuff work as the stabilizers for shoulder joint? So if you see the red color arrows in the image, they are representing the 4 important muscles of the rotator cuff: the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. If you see the direction of force, the arrows that have been shown here representing the muscles are also representing the forces that are created by the rotator cuff. So if you see, this is the superior view and this is the posterior view. So in both these images, if you see the direction of forces produced by the rotator cuff, it is trying to pull the head into the glenoid cavity. So all these muscle forces in some or the other way are trying to push or maintain the head of humerus into the glenoid cavity. And that is the reason we call rotator cuff as the stabilizers or primary stabilizers of the shoulder joint. Why? Because all of this rotator cuff muscles, even at a resting position, okay, are creating some kind of forces which maintains the head into the glenoid cavity. Right? Now, if we talk of the arm, there is a weight of the arm. My upper limb has weight. So even if I am hanging the hand by my side, my shoulder does not subluxate interiorly. Even if I carry say 5 or 10 kgs of weight in my hand and I walk, my shoulder does not subluxate inferiorly. That is because I have a lot of stabilizing structures around the shoulder girdle or glenohumeral joint, which includes the rotator cuff as a very important component. Now we will also see further that how does this rotator cuff help in doing the motions or preventing certain problems at the shoulder girdle. Talking of the muscles, we have already discussed this. The latissimus dorsi, the upper fibers of trapezius, the middle fibers, the lower fibers of trapezius, the rotator cuff, supraspinatus, infraspinatus, the subscapularis, and the teres minor. Quickly, we will go back to the previous slide and just discuss that what are the different functions of rotator cuff. The subscapularis does the internal rotation. It is a very strong internal rotator. Supraspinatus does elevation of the humerus, right, during abduction. Infraspinatus and teres minor are the external rotators of the rotator cuff or glenohumeral joint. And recently we have also got some studies which say that long head of biceps, which comes anteriorly, is also a functional part of rotator cuff. Means it works as a rotator cuff group of muscles during the motions of the shoulder. Okay, we have a small video here. If I'm able to play it. Okay. So what we are trying to show here is that basically when the scapula, the resting position, you can see the acromioclavicular joint here, right? So when we talk of the motions of the scapula, what is important is that the subacromial space, that is here, between the head of humerus and the acromion process, this space should always be maintained throughout the range of motion of the shoulder joint. Only then the structures that come under the acromion process, the subacromial structures, that is the subacromial bursa, the supraspinatus tendon, the rotator cuff tendon, will not be impinged. So when I do the abduction, the acromion process, because of the motions of the scapula, if for example, this is the scapula, this is the acromion process, this is the head of humerus. So every time I do a motion, there will be a constant space which will be maintained between the acromion process and the head of humerus, which will prevent the impingement. If there are no motions of the scapula, if it's only the humerus, it will constantly create an impingement on the subacromial structures, which leads to subacromial impingement syndrome. A lot of cases where you have abnormal motions of the scapula, as we talked previously about scapular dyskinesia, which is basically the abnormal motions of scapula. This leads to a lot of impingement problems. So people who have, and it has been found that even normal healthy individuals do have some amount of scapular dyskinesia. Okay, at least 70% of people will always have some or the other kind of scapular dyskinesia. And such people are more prone to impingement syndromes or injuries around the shoulder. This component of scapular dyskinesia to be assessed is very important in overhead athletes. Why? Because they play a lot of overhead sports, and if they have these abnormal motions of the scapula, then definitely they are more exposed to injuries around the shoulder joint. We'll just go through the video here. So if you see the video, okay, sorry, go back. So if we go through the video here, right, what we see is that so we have a video here which basically shows that how does the full shoulder abduction occurs with scapulohumeral rhythm, right? So if you see here, right, and throughout the motions, okay, there is a motion of the clavicle, there is a motion of the sternoclavicular joint here, there is a motion of the acromioclavicular joint, right? So that is what we were talking about when we talk of biomechanics, that it is not only the glenohumeral joint. You also see here carefully that there is some amount of space that is being maintained into the under the head of between the head of humerus and the acromioclavicular joint that we see here as well. And this motions basically should be maintained. So 120 degree of glenohumeral motions here. Okay, or some amount of 45 degrees of external rotation of the glenohumeral joint. Elevation or 25 degrees of sternoclavicular elevation, right? Okay, there is a 35-degree upward rotation of the acromioclavicular joint. Okay, so 25 to 30 degrees of motion that the sternoclavicular acromioclavicular joint will make the scapular motions, right? So what we see here is basically that the sternoclavicular joint, the acromioclavicular joint, these motions are also important on having motions of the scapulothoracic joint, which together makes up the whole 180 degrees of scapular motions. Okay. So now talking about what provides scapulothoracic stability. Stability of the scapula on the thorax is provided by the structures that maintain integrity of the linked acromioclavicular and sternoclavicular joints. The muscles that attach to both the thorax and the scapula maintain contact between these surfaces while producing movements around the scapula. So this anatomical structures, the muscles mainly, which connect the scapula to the thorax and other joints, helps to maintain the scapula and the acromial clavicular and the sternoclavicular joint in space or in its place during scapular motions. In addition to that, stabilization is provided through the scapulothoracic musculature by pulling and compressing the scapula to the thorax. So what does this muscle do? They help the scapula to stay connected or closer to the thoracic wall and not go away from the thoracic wall. Next, what we have is the scapula is and its associated muscles and linkages can perform stability and mobility functions and also serve as dynamic stabilizations for the human body. Right. Then talking about angle of inclination, the angle that the head of humerus makes with the shaft is what we call as angle of inclination. These are normal anatomical angles, which are very important for motions of the scapulohumeral rhythm. And we have angle of torsion, that is when you see the head of the humerus superiorly in line with the condyles of the humerus, there is a slight rotation of the head of humerus probably the medial rotation, which we call as the angle of torsion, which is normally around 30 degrees. Okay, so angle of inflation is the angle formed between the head of the humerus and the longitudinal shaft of the humerus. And torsion is where the head of humerus makes the angle with the condyles in line. Glenoid labrum. Glenoid labrum is an important structure which helps to provide stability to the head of humerus. As we know that head of humerus is 3 times larger compared to the glenoid cavity. So how do we get the stability is by the labrum. The primary stability comes from the labrum. It enhances the depth of the fossa by 50%. It is a radiolucent fold of dense fibrous connective tissue with little fibrocartilage. This is the anatomical composition of your glenoid labrum. It is attached to the glenohumeral ligament and long head of the biceps brachii. So your long head of the biceps brachii is the only muscle that enters into the capsule and attaches over the supraglenoid tubercle and has an attachment to the labrum as well. So in a lot of cases where you have overpulling of the biceps, right, or you have pull of the biceps, there are chances that you may have associated labral tears because the long head of biceps is somewhere connected to the glenohumeral ligament at the labrum. Functions: it helps to resist the humeral head translation, protection of bony edges of the labrum from wear and tear, reduction of joint friction, and it dissipation of the joint contraction or contact forces. We have 4 joints. We already discussed this: the acromioclavicular, the sternoclavicular, the scapulothoracic, and the glenohumeral joint. Okay, so the SC joint connects the component of shoulder joint to the axial skeleton. This puts greater demand on the muscles for securing the shoulder girdle on the thorax during static and dynamic conditions. Clavicle, humerus, and scapula are linked with 3 interdependent joints: the sternoclavicular, the acromioclavicular, and the glenohumeral joint. In addition to this, a functional joint called as the scapulothoracic joint. We already discussed this. That's not a true joint, but it is basically a very important functional joint which puts the shoulder through a full range of motion. And all this together is called as the shoulder complex. Right? It's just an image which is showing us different types of joints and the muscles and the ligaments per se around the shoulder girdle. Talking of sternoclavicular joint, it is a plain synovial joint with 3 rotatory and 3 translatory freedoms. We saw that elevation, depression, okay, anterior rotation, posterior rotation, and protraction and retraction that occurs along with the scapula. Right? So these are the structure showing the acromioclavicular joint. We have the interclavicular ligaments, the costocoracoid ligaments, the first strip which connects with the clavicle here, and with the sternum as well, giving a further stability to the clavicle. Then we have sternoclavicular motions: 3 degrees of freedom, elevation, depression, protraction, retraction, anterior and posterior rotations, and 3 degrees of translatory motion, that is anterior, posterior, medial, lateral, and superior and inferior. Here is the image showing us the elevation and depression of the clavicle, right? So clavicular elevation occurs up to 48 degrees with full flexion, and passive clavicular depression is less than 15 degrees. Here we have the protraction and retraction, posterior and anterior rotation. Posterior rotation is around 50 degrees and anterior rotation is less than 10 degrees. This is where we have the protraction and retraction that occurs along with the scapular protraction and retraction. That is around 15 to 20 degrees, and retraction is 20 to 30 degrees. So all of this range of motion that we saw previously for the clavicle, right, in all these 3 images, are again an important component to have full shoulder girdle motion. Now just imagine that when we do not focus on mobilizing all these 3 joints, right, or all the other joints apart from glenohumeral joint, and we expect to achieve full range of motion, then it's next to impossible, because we need the motions of the whole shoulder girdle that includes your sternoclavicular, the acromioclavicular, and the scapulothoracic joint in order to complete full 180 degrees of range of motion for the shoulder, whether it's flexion or whether it's abduction. We do need this motions at the other joints as well. Now, how do these sternoclavicular joint tolerates the stress? Strong forces dissipating from structures such as sternoclavicular disc and the costoclavicular ligament. This minimize the articular stress and also prevent the excessive intra-articular motions that might cause subluxation or dislocation. Right? So we have a disc which is called as the sternoclavicular disc, that is between the sternum and the clavicle. We have the costoclavicular ligaments. These are some structures which reduces the stress coming on the sternoclavicular joint, thereby preventing injuries to the sternoclavicular joints. Then we have rotator cuff interval capsule, the superior glenohumeral ligament, right? Then the superior capsule and the coracohumeral ligament. Okay, these three structures that we see. Okay, these three structures are interconnected structure that bridge the space between the supraspinatus and the subscapularis muscle tendons, which is called as the rotator cuff interval. So if you see, the supraspinatus comes like this. Okay, you can see the supraspinatus muscle here. The subscapularis muscle comes here, right? And there is some space that is left open between this. If this space was open, then we would have more injuries or we would have more damage to the shoulder joint. So what did the shoulder was designed in such a way that the space that is there between the supraspinatus muscle and the subscapularis muscle is covered up by three structures, that is the superior glenohumeral ligament, the superior capsule, and the coracohumeral ligament, which together is called as the rotator cuff interval capsule. Why is the name so? Because it is covering up the space between the supraspinatus and the subscapularis muscle. That is why it is called as the interval between the supraspinatus and the subscapularis is covered by these three structures, and hence together they are known as rotator cuff interval capsule. Intraarticular contribution. The concave convex humeral head is a substantially larger surface and may have different radius of curvature than the shallow concave fossa. Even this incongruence, rotations of the joint around it, three axes, do not occur as a pure spin, but having changing centers and shifting contact patterns within the joint. So now what happens is there is a very large head of humerus and the glenoid cavity is smaller. So when you do the motions of the head of humerus into the smaller glenoid cavity, it is not pure spinning. There will be constant change in the center of rotation. So what is center of rotation? For example, if I'm spinning a football on my finger, then the place where I'm putting my finger on the football to spin it is the center of rotation. Now, if it is constant, then the large head of humerus will cause a lot of stresses on the glenoid cavity or on the labrum. So the shoulder is designed in such a way that with every degree of motion of the shoulder, there is a constant shifting of the center of rotation. Means in the beginning, if it is in the center point, when it starts rotating, it will keep moving from one point to other in order to create less stress on these joints and have a full range of motion. So without downward sliding of the articular surface of the head of humerus, the humeral head will roll up into the glenoid fossa and causing impingement on the coracoacromial arch. So in case if this center of rotation was not shifting constantly, okay, then what would have happened is that every time we used to rotate the head of humerus or move the shoulder into range of motion, the humerus would have translated superiorly, causing impingement over the subacromial structures. Now, what is the advantage of having this rotation or center of change in the center of rotation is, once I start doing the motions, the head of humerus slides downwards, okay, and this creates a constant space between the subacromial or under the subacromial space, so that the structures that come under the subacromial space do not get further impinged. So if we talk of simple motions, okay, then it's just flexion, extension, abduction, adduction, interlaced rotation that occurs around the shoulder. But if we go into the depth of the biomechanics, where we talk of arthrokinematics, that are the motions occurring within the joint, spin, roll, and slide, then the importance of this rolling, sliding, and spinning is such that if we have these motions, we can prevent a lot of impingement or other injuries to the shoulder. In case if this spin or rolling and rotations were absent, then this would lead to more and more impingement. So people who have more of impingement syndrome may have problems either with rotation, spinning, or rolling of the head of humerus into the glenoid cavity, or will have the problems with scapular motions, or will have combination of both. If you see here, when I was at a resting position, that is position 1, okay, the head of humerus, the center of rotation or glenoid fossa was here. Okay, and this is where we have the center of rotation, a circle with a dot, right, in black color. As I moved from position 1 to positions 2, say 90° of shoulder abduction, my center for glenoid fossa has shifted here, and my center of rotation has shifted here at point 2. If this would have not occurred, the head would have translated superiorly, causing impingement. So this rotation or spinning and rolling within the joint is equally important to have a proper normal range of motion at the joint without creating any impingement. So slight superior translation of the center of the head of humerus can still occur during shoulder abduction despite inferior sliding of the head of articular surface. So there will be some translation. Definitely we will have some amount of translation, but that would be somewhere around 1 to 2 mm only, which does not hamper the subacromial structures. But if this increases, the superior translation increases, then this would lead to more and more impingement. And we will see that how does this superior translation increases, in what cases or where do we have increased superior translation of the head of humerus. Okay. Now we have static stabilization when the arm is unloaded. So when the arm is unloaded, that is when you are putting the hand on by your side, we are not doing any movements or we are not carrying any weights. Okay, we have two force factors. One is the forces generated by the rotator cuff interval capsule. Like I said, 3 structures, okay, which makes up the rotator interval capsule. And then there is a line of gravity which pulls the head of humerus down. So the resultant pull comes here, which maintains the head of humerus into the glenoid cavity and does not allow it to subluxate inferiorly. So the forces by the interval capsule of the rotator cuff creates a force that helps the head of humerus to be maintained into the glenoid cavity. Loaded up when I start moving, okay, the force generated by the rotator cuff interval capsule is not enough. So once the supraspinatus activity starts, when the passive tension rotator cuff interval is insufficient, as in loaded up. So once I start doing the movement, the rotator cuff interval capsule fails to generate enough force to maintain the head of humerus into the glenoid cavity. And this is when my supraspinatus gets activated or starts getting recruited in order to overcome the loads that are being put on the upper limb during shoulder motions. So once the arm has been started loading, immediately the supraspinatus will get activated to maintain the head of humerus into the glenoid cavity during arm motions. And this is how the rotator cuff plays a vital role in dynamic stabilizers. Moving further, what is the effect of deltoid alone in the absence of supraspinatus? So what happens if we did not have supraspinatus? So if we did not have the supraspinatus, the deltoid would have created superior translation, which would have caused more impingement. So just imagine that this is the acromion process. This is the head of humerus. And when I have strong contractions of the deltoid, my head of humerus will cause superior, or my head of humerus will go into superior translation, which will cause further impingement of the subacromial structures, right? So this is where the deltoid comes. This is the head of humerus. And every time I do abduction, I don't have a supraspinatus, which helps me to move the head down, right? And elevate it up. So what happens? That I will have more and more impingement. Why? Because there is a superior translation of head of humerus, which will cause impingement or compression of the subacromial structures. So in patients where we have insufficient supraspinatus, means there is a supraspinatus tendinitis, there may be a supraspinatus tear, or there may be involvement of supraspinatus, which has led to weakness of supraspinatus. In those cases, please do not focus much on strengthening the deltoids, because in the absence of supraspinatus or in the weakness of supraspinatus, the deltoid will create superior translations, which will create impingement of the subacromial structures. So that is the reason that the body has been designed, or the shoulder has been designed in such a way that you have a supraspinatus, which creates initial abduction of the head of humerus or humerus, and then the deltoid takes over it. So supraspinatus, it not only creates initial abduction, but it also pulls the shoulder downwards and then rotates it. It is this movement. Please understand, it's not this. It is like this. This is what we saw in the previous image, right? That there is some rotation, downward rotation of the scapula, if you see of the humerus, sorry. Right? Now this downward rotation of the head of humerus is created by supraspinatus. Hence, what supraspinatus does is not only creates initial abduction, but it rotates the head down, pulls it down, rotates it like this, so that the deltoid can do abduction without creating any impingement. Right? So we have four muscles, like we said, supraspinatus, infraspinatus, teres minor, and the subscapularis. Now, what is the resultant force of infraspinatus, teres minor, and subscapularis? They individually have the similar pull of line. So when you have two forces acting in the opposite direction, the resultant force will be in the third direction. We already know this. Okay. So here is where I have infraspinatus, the teres minor, and the subscapularis. All these three muscles, they may help to maintain the head of humerus into the glenoid cavity. So now what provides the stability to the head of humerus? One is the glenoid cavity. Other is the rotator cuff, mainly the infraspinatus, teres minor, and the subscapularis. Along with this, there is a negative pressure within the joint capsule. It's like a vacuum. You have a negative pressure within the joint capsule, which also helps to maintain the head into the glenoid cavity. Okay, so it will help to maintain the head by creating negative pressure into the capsule by holding it. Right. So these are primarily 3 or 4 components which help to maintain the stability of the head of humerus. The rotatory component compresses as well as rotates the translatory component helps offset the superior translatory pull of the deltoid. So deltoid creates elevation. These three muscles of the rotator cuff creates downward pulling of the humerus. So when the deltoid gets activated to abduct, these three muscles along with subscapularis get activated to rotate the head of humerus downwards so that you can prevent impingement. Okay. So supraspinatus and humeral stabilization. The supraspinatus has a superiorly directed translatory force. This is the force of supraspinatus, and the rotatory component that is more compressive than the other rotator cuff muscle. So compared to these three muscles that we see here, the infraspinatus, the teres minor, and the subscapularis, supraspinatus have a greater role to pull the head into the glenoid cavity compared to other rotator cuff muscle, and it can independently abduct the humerus. Okay, so even if there are injuries to the other rotator cuff muscle, supraspinatus alone is enough to create abduction at the glenohumeral joint. Coming to long head of biceps, I told you that recently the long head of biceps has been considered as the functional component of the rotator cuff. Why? Because it provides anterior stability. So the long head of biceps may produce its effects by tightening the loose superior labrum and transmit increased tension to the superior and the medial glenohumeral ligaments. Okay, so long head of biceps enters into the capsule, attaches over the supraglenoid tubercle, and it helps the tightening of the loose superior labrum, thereby preventing anterior displacement of the head of, because the deltoid comes anteriorly. Okay, so what it does is it prevents the anterior translation or shifting of the head of humerus. And that is why in cases where you have anterior dislocation, you may have an injury to the labrum along with injury to the long head of the biceps. The long head of biceps brachii, because of its position at the superior capsule and its connections to the structure of the rotator cuff interval capsule, it is sometimes considered to be a part of reinforcing cuff of the glenohumeral joint. The biceps muscle is capable to contribute the force of flexion and can, if the humerus is laterally rotated, contribute to the force of abduction and anterior stabilization. The bicep may not only do flexion of the humerus, but if you laterally rotate the shoulder, it can help in abduction and provide anterior stabilization as well. And for today's session, thank you all of you for patiently listening to me. And I hope that this session has provided some insight to you about the anatomy integrated biomechanics and will help you in future to reconstruct or to construct your rehabilitation protocol, keeping in mind the biomechanics and its integration, or anatomy and its integration with biomechanical principles. Thank you again.
Yes. So it's really been an interesting talk. I'm sure if we had live listeners, we would have had many questions right now. For me, it was like a revision of the biomechanics. And I'm sure that all our listeners would agree that I think anatomy and biomechanics are so connected or integrated with each other. And if we kind of bring in the special points. I guess when students are taught anatomy, if we can kind of teach biomechanics along the same time or the same year, it would enrich their experience of not only knowing anatomy, but also the biomechanics.
Yes.
And even when we teach them in the second year or the following year, I guess the way you have taught it, wherein you have integrated the anatomy and aspects of anatomy and purely taught it with such beautiful slides. I think one should definitely agree that sir had minimum text and maximum diagrams. So it was so well, and you also used a lot of annotations, by pointing out things and, letting the listener know that how the slide, the roll, the rotations take place to kind of enhance the movement, along with how the rotator cuff capsule acts, the ligaments support each other, how the labral adds to the stability. So all in all, I guess, because of the way sir has taken the lecture, it has added, I think it has made shoulder biomechanics very easy. I'm sure I'm going to kind of project this talk to all the second year students, and I'm going to wish that every university shows this talk to their students to just enhance their understanding about the entire shoulder. So I would like to personally thank you, Dr. Dharmang, from the entire Physio TV team. And it was really a very enriching talk. I'm sure we are going to invite you again for more talks. I'm sure you
So
have a
much, ma'am.
lot in your kitty with you, because you're already coordinating the fellowship program in shoulder and knee. And it just shows how the fellowship program itself must be so informative and so enriching. So even reaching
Thank you
out to
so much, ma'am.
physiotherapists out there, anyone who is interested in fellowships at Parul University, kindly look at this video and consider joining it for Dr. Dharmang Vyas. Thank you so much, sir.
Thank you. So the main reason for integrating this anatomy was that because we study anatomy in the first year. In the first
Yes,
year, we
sir.
focus more on the anatomy part now.
Yes.
And when we teach biomechanics, actually the people who teach biomechanics also do not integrate so much of anatomy. And that is the major issue that we face during restoration of biomechanics when we talk with patients. Like in cases where we want to treat the patient, where we are rehabilitating an athlete, or we are as a part of a sports team, we do not integrate this anatomy into biomechanics, where we can prevent a lot of injuries rather than treating the injuries.
Exactly.
If we integrate all of this,
exactly.
definitely it will work wonders.
In
And
fact, that's our strength,
Yes, and
compared to
specifically
other
those who are with
professionals.
musculoskeletal and sports related physios, those who are and
Without
sports
doubt.
is going very high these days. So I
Yes,
think
sir.
this should be integrated somewhere into their biomechanics.
Without doubt. In fact, the entire biomechanics should be our strength, because ours is one profession which is kind of dealing this in details. So we
Definitely,
should
ma'am.
have biomechanics as our strength.
Yes. And ma'am, we as a physical
And deal with
therapist,
it.
we have techniques to restore biomechanics. See, a lot of
Without doubt.
orthopedic surgeons do believe that there are biomechanical faults, but they do not have a technique where they can restore this biomechanical faults. Whereas we as physical therapists, we know a lot of techniques, or we do a lot of things where we can restore this biomechanics. So I think we play a very
That's what.
important
So
role in.
exactly. So a clear understanding of what the normal biomechanics is,
Yes.
and then knowing what has gone wrong and trying to correct the fault, is very important. So I guess this talk will go a long way in doing just that if physiotherapists listen to this
Thank you, ma'am.
properly. So yeah, thanks for the entire Physio TV team. We thank Dr. Dharmang. Thank you so much, sir.
Thank you, Physio TV team, Sancheti Hospital, Sona ma'am, for inviting me as a resource person for this talk. Thank you so much, ma'am.